Good morning or afternoon or evening to you wherever you may be. My name is Brennan Mandel. I'm the Director of the Innovations Program at Jhpiego, and I would like to welcome each of you to Deliver, the third and final webinar of the series, Ideation to Impact. In this session, you'll hear from some thought leaders and seasoned practitioners working in global health financing, implementation, and advocacy as it relates to delivering on our promise of life-saving maternal and newborn health technology. We know many of you represent a vast array of disciplines and experience, and you've joined today because of your interest in and commitment to maternal and newborn survival. For that, we thank you. Jhpiego has chosen to convene this webinar series to capture some of the momentum and diversity of expertise, as well as to surface some of the exciting work that is happening, believing very much that the meeting of unlike minds and greater collaboration is the key to all of our success. I'd like to thank Sage Innovation for helping develop and organize this series. If you missed the first two webinars, they are available on jhpiego.org and address key considerations related to design and development. In this webinar, the topic will focus on delivery and how different actors can help inform the sustained financing, introduction, and scalability of maternal and newborn health solutions. It is now my honor to introduce Ms. Katja Everson as the moderator for this webinar. Ms. Everson is the Director of Women Deliver, a global advocacy organization dedicated to improving the health and well-being of girls and women. She has more than 20 years' experience working in NGOs, corporations, and United Nations agencies, and shares a passion for the issues we are discussing today. Ms. Everson?
Yes, thank you very much, Brennan. And thank you everybody for joining this webinar. I am very pleased to be moderating it, the third and final session, aptly named Deliver, because that's what we're here to do. For those of you who may not know me, I just joined Women Deliver, but as Brennan said, have been working in the field of maternal, newborn, and child health for a long time. I'm very excited about these webinars, and I've listened into the two fabulous sessions that preceded this one, and because we're focusing on solutions. Women Deliver always seek to highlight solutions through our global advocacy and messaging, our global conference, and the other activities we have. We have seen and we know that there is a pipeline of hundreds of emerging innovations, technologies, and programmatic solutions that are either proven game changers or are very promising. So we have the keywords deliver, solution, and scale. We know that things take a long time to get adopted and scaled. When innovations don't get executed, we are missing opportunities to improve health and save lives. So some of the key questions that we will address in this webinar are: what needs to be done to execute on our innovations? How do we move life-saving technologies and solutions to sustainability and scale? We know that there are critical roles for advocacy groups like Women Deliver and others, implementation partners, donor communities, and health systems to inform the national and global decision-making, sustainable financing, and compatibility with programs and other public health investments to ensure delivery, because that's what we're here for. But let me introduce the distinguished panelists. I will start with a next slide, please. Neil Brandes. Neil is a Senior Health Research Advisor in the Office of Health, Infectious Diseases, and Nutrition in USAID's Bureau of Global Health. He oversees a research-to-use portfolio inclusive of maternal, newborn, and child health and infectious diseases research, technology development, as well as research, translations, and introduction activities. And prior to joining USAID, Mr. Brandes worked for Robert Wood Johnson Foundation and the National Academy's Board on Science and Technology for International Development. Next slide. After Neil, Andrew Taylor will speak. Andrew D. Taylor is Executive Vice President of Grand Challenges Canada and is responsible for the STARS in Global Health and Transition to Scale programs. Leading a team of investment and scaling experts, Mr. Taylor is focusing on developing and implementing a scaling strategy to translate bold ideas into big impact. The focus on the strategy is to catalyze smart partnerships and to leverage private capital and know-how to transition bold ideas along the path to scale towards sustainable impact. Prior to Grand Challenges Canada, Mr. Taylor worked overseas in the biotech industry with a focus on sales, marketing, and business development. Welcome, Andrew. And then we will have Harshit Sanghvi. As Vice President and Medical Director of Jhpiego, Dr. Sanghvi is responsible for leading the organization's technical and clinical approach by designing and implementing effective, low-cost, hands-on solutions to strengthen the delivery of healthcare services for women and their families worldwide. He has extensive experience assisting more than 45 low-resource countries to adopt evidence-based guidelines, design training systems, develop health leaders, scale up programs, and seek innovative solutions to improve the performance of health services for women. In 2009, he was the recipient of Global Health Council's Best Practice Award for his work in postpartum hemorrhage, and just last week, Jhpiego received the United Nations Population Award. And our last speaker will be Karen Clune. As Global Health Bureau's Innovation Advisor at USAID, Karen helps identify and develop initiatives, partnerships, and activities that support innovations in global health. Karen manages the Saving Life at Birth Grand Challenge Partnership and projects which aim to dramatically reduce maternal and neonatal mortality and stillbirth. Prior to USAID, Karen was the post-operative program manager with Operation SMILE, a nonprofit organization providing free facial reconstructive surgery to children around the world. So Neil will be our first speaker, and he will be speaking on how evidence of success can be leveraged to establish global consensus and urgency to deploy a new solution tool for widespread use. So Neil, will you take it from here?
Yes, thank you. So what I'm going to do in a brief period of time is to walk you over basically a decade of work. So 8 minutes, hopefully, and 10 years. So the overview I'm going to provide to all of you is of a managed research to use process that AID employs to try and accelerate the process of moving from proof of principle to scale up. So in the public health community, if you can move to the next slide, one of as the previous speaker mentioned, if we could move to the next slide, I need, please. There is the great debate over how do we move quickly, what are the challenges, and Larry Green a number of years ago did an estimate that in fact he describes it as a 17-year odyssey from sort of priority setting to full scale up in use and practice. So what I'd like to do, turning to the next slide, is to deconstruct some of the factors that in fact challenge us in moving in that process. So in the research community, often the researchers, if you look at the right side of the slide, focus on the issue of design of studies and the challenges of doing that. But in fact, we need to understand this in a much broader context. That the impact of the setting of the environment where the ultimate intervention is implemented, to the characteristics of the intervention, the product, or the approach, and then the interaction of all three of these factors that influence how an intervention can actually move or be used. And any one of these pieces can derail your process. If we move to the next slide, David Peters has described actually along with some of his colleagues at the World Bank, challenges at the end of the cycle, which in fact can be quite disruptive in nature. And they range, as you'll see on the slide, from the issue of local adaptation of something that's been developed in a research setting to the whole issue of powerful interest groups may interfere, that may be threatening to a group, and the need for constraint and reduction plans in undertaking such work as part of the adaptation process. If we move to the following slide, this is actually an illustration of our attempt to adopt a concept from industry known as the value chain. And what we did this is essentially a conceptual model to help us articulate the steps that we undertake in moving from basic research to use. And working across it reflects some of the key steps that one would do in this process, whether one's in a private sector organization or a public sector organization. It begins with the whole concept of prioritization of a promising area compared to other possibilities to move forward, and then it encompasses, although it's difficult to show a 3D model, the concept, in fact, that it's not necessarily a linear process, that one may undertake work in developing a product at the same time that one has to work on regulatory manufacturing issues as well as feasibility issues concurrently. So if we move to the next slide. So the topic I want to briefly touch on today is an antiseptic that we supported research on and how we moved it forward in this process. So for many of you know that newborn health has recently gotten a fair bit of attention from the global community. Specifically, a few weeks ago, it was actually highlighted as part of the World Health Assembly with the launch of the Newborn Action Plan. When one understands the place of newborn mortality in a broader context, when one looks at child health and child mortality, newborn health over the last few years has become an increasingly larger portion of under 5 child deaths. And within the causes of newborn mortality, infections are among the leading 3. So beginning with a study in Nepal that NIH funded, a research team from Johns Hopkins looked at the potential of the application of an antiseptic, this being chlorhexidine, on a newborn cord, as essentially acting as a barrier against the entry of pathogens into the newborn's body after the cord is cut. So if we move to the next slide. So what I'm trying to do in this slide is to give all of you a sense of the time frame it takes to really move from this first step of one has a promising idea and moving it to full scale. So again, I mentioned the NIH study in Nepal. That led us as a group to convene a consultative meeting along with NIH colleagues to review the evidence around chlorhexidine as an antiseptic and its potential uses, potential dangers of using it. And the group that we assembled, which is very much reflective of the approach one needs to accelerate a process, is bringing around the table partners with different expertise. So we had at this meeting the researchers and a research community who had worked on antiseptics and specifically chlorhexidine in different modalities. We brought a manufacturer to the table who in fact had expertise in this area, along with groups like US Pharmacopoeia who have expertise in the whole area of regulatory issues, as well as implementers who could guide us on in the design of a study that might make sense moving forward. So we as an organization worked with research partners to initiate 2 proof of principle studies in Bangladesh and Pakistan. But shortly after we started these studies, and this is what one might see in industry, we actually funded some parallel work in product development to refine the final product, as well as feasibility studies looking at if the proof of principle studies validated the initial work in Nepal to really accelerate that process. So even in those early stages, we began to put in regulatory applications. In this case, to the WHO Essential Medicines list to get chlorhexidine added. It's one of the steps along the way to move forward with when the evidence was ultimately out. We then, in the case of Nepal, which already had some evidence, the government of Nepal was convinced that there was something promising, and it began to do effective stroke, maybe one might call feasibility research at looking what would the intervention actually look like in a real life setting. So somewhere between, you might call it phase 3 or even almost phase 4 studies. As that evidence rolled out, Nepal, the government of Nepal was sufficiently convinced that its evidence was strong enough to move towards national policy, even before there was a global consensus. Now, this may not always be the case with an intervention, but in this one, it certainly was. So we convened, as the various studies came to an end, a meeting in Nepal hosted by the government of Nepal, where we brought together all of the study teams of the various phases, from proof of principle through feasibility and even some of the product developers, to really review the evidence. We then, if one understands moving forward, this whole process was really accelerated by a grant that Nepal received from Grand Challenges that allowed Nepal to more rapidly scale up than it would have otherwise. Then, with this ongoing process, we and others were able to bring teams to Nepal to look at the work in practice, and that has led to, in fact, us to convene a working group that brought together various parties, much as we did at the beginning of the effort, from the various communities around the table, much like you might see in a private sector company, but a broader community. And the net result of this effort, in fact, has been that we've moved quite rapidly to working with countries who were interested to introduce chlorhexidine in their countries. So as you'll see on the slide, by 2013, there are 15 countries where this work is ongoing. So moving to the next and final slide. I mentioned the chlorhexidine working group in sort of the top table of this. And we have asked Pat to serve as the secretariat of this effort. And as you can see from the slide, the community of groups which are working on this effort in conjunction, it's an open-ended effort that involves philanthropic organizations, academic organizations, manufacturers of the product, including Lomas, which is the manufacturer in Nepal, which was the first group to produce chlorhexidine on a commercial basis, and NGOs and UN agencies, along with AID. And I guess I'd like to conclude in mentioning that it's this open-ended approach of doing things not necessarily always sequentially, but looking at opportunities to parallelly, but also the critical element is having this broad communities of different areas of expertise to move forward an initiative. And I'd like to conclude by inviting you to look at the more detailed information about this effort and the ongoing country efforts hosted by the Healthy Newborn Network group, which is Saving Newborn Lives, hosts this for us. And for those interested, you're more than welcome to join this effort. Thank you for your time.
Thank you very much, Neil, and thank you very much for the invitation. I sure will have a look at that website and the great work you're doing, and I'm sure many others will as well. Now I would like to give the floor to the second speaker. It's Andrew Taylor, and Andrew will be speaking about financing for maternal newborn health innovations.
Great. Thank you very much, and it's an honor and pleasure to be on the webinar today. First off, Grand Challenges Canada, just so everyone knows who we are, we're dedicated to supporting bold ideas with big impact in global health. We're funded by the Government of Canada, and we fund innovators in low middle income countries and in Canada. And since May 2010, when we officially launched and we were originally developing our strategy and our focus, we came across a report by the Acumen Fund and by Monitor and others. It was called The Blueprint to Scale, the Role of Philanthropy in Development. And one of the key aspects of that report was the perspective of impact investors, where essentially they're saying that there is a need for more opportunities and more pipeline to be able to look at. So back in 2010, we were really thinking that through. And one of the areas that we've been focused on is really building a robust pipeline of innovation. So if you go to the next slide, this is a bit of a crazy slide, but this is one of our programs called Stars in Global Health. And through 6 rounds, we have about 392 innovations at about $100,000 idea stage, and this just shows the 81 countries of where the implementation is currently being undertaken. So essentially what we're talking about today and the next really focus of Grand Challenges Canada is around a potential risk that in 2 or 3 years' time we do not want to be known as the organization stuck in pilotitis, where we have all these great ideas, but we're not able to actually take them to scale. So if you go to the next slide, this is a challenge that I think we all share, and that is collectively as a community, how do we catalyze, enable, and transition innovations to scale in a sustainable manner to save and improve lives? To me, sustainability is the key word. I think the majority of the people on the panel today, I think all of us and others that are listening will agree that there is not enough philanthropic and arguably public dollars to really support the sustainability of these innovations. And I've been arguing that we as funders, and I think there is broad agreement amongst funders, that we need to innovate ourselves and to develop new ways of financing these innovations and tapping into new investment type dollars into these innovations. I do want to say going forward that of the approximately 500 total innovations, the 400 within the STARS program, the majority of those are in the area of maternal, neonatal, and child health. So if you go to the next slide, and it really is the question, well, how are we tackling this scaling challenge? And I like this slide just because it really shows that we're taking this really from a private sector lens by looking at the ways in which venture capital, private equity, but we also realize this is development. So we're also bringing in the world of impact, social impact, and development, and blending it all together and seeing what comes out. And where we're trying to get to is the unlocking of social finance to scale integrated innovations, which I'll touch upon, by catalyzing sustainability through partnerships. So there's that sustainability word again, and a strong emphasis on partnerships. So if you go to the next slide, over the past 2 years, we have been experimenting with different innovative financial models that applies, which is really our thesis, how do you apply public dollars to leverage investments and either public and private and partnerships. And essentially what we're developing at Grand Challenges Canada is a laboratory of financial innovation models. So I'll go through each one of these. I'll spend more time on the direct investments and go through a couple of examples, but we're working at the level of social enterprises and small and medium-sized enterprises. The second is really around shared or blended value, and it's defined as a management strategy focused on companies, multinational companies, creating measurable business value by identifying and addressing social problems that intersect with their business. This is not corporate social responsibility. And the great example of this is through our through the Saving Lives at Birth initiative that Karen will mention when she talks. And essentially the example is the picture on the top right, which I won't go into a lot of detail, but this is the Odin Device. It's a fascinating innovation that is addressing challenges of obstructive labor and delivery. If you haven't heard about this story, Google on New York Times and you'll see the story of Jorge Odin and his brilliant idea, which got picked up by the WHO and provided seed funding through the Saving Lives at Birth initiative. And then it attracted a large Fortune 500 company, Becton Dickinson. And the Saving Lives at Birth funders have really been working closely with Becton Dickinson to be able to bring this into their portfolio. And it is a great example of what we term shared value. Third is impact investment funds. Last year, Grand Challenges Canada made an anchor investment into the $108 million Global Health Investment Fund. The novelty around this is the fact that investors are partially protected against financial loss through risk-sharing guarantees. So it's, again, how do you use philanthropic public dollars to leverage in private investors. This is exciting because it's the first global health fund that takes an impact investment approach to balance both social and financial return. And then finally, development impact bonds. There's a lot of buzz around impact bonds, both on the domestic and international level. My point here is that this is extremely high risk and a long-term play. Therefore, it requires a lot of experimentation. And as a development community, we need to be really good at sharing lessons, what works, what doesn't work. But again, high risk, long-term play. Now going into a bit of the details to really touch upon the importance of sustainability through partnerships. If you go to the next slide, I'm going to go through, probably in the interest of time, two examples. One is the first one around Soil Haiti. This is a social enterprise led by two great social entrepreneurs. One, Sasha Kramer, was named the 2014 Schwab Social Entrepreneur of the Year. And they're currently developing a for-profit model with revenue from monthly toilet user fees, waste treatment fees, and compost sales. This is a great example of integrated innovation. And the concept of that is to really address a challenge. You have to look at it from a science and technology innovation standpoint, but more importantly, a social innovation and a business innovation. So Sasha and Leah and the team have been really working at the grassroots level to say, what type of innovation is needed around toilets? How is this going to be accepted? Will you actually pay for it? Is it affordable? Is there a business model around this? So what we're doing is we're actually working with Soil Haiti and a team of different, or a group of different smart partners within the region of Haiti to really develop a for-profit type of model that in a couple of years from now they'll be ready to actually turn and say, okay, we're ready for private investments. We want to move more towards a sustainable model. So that's an example of something a little bit more upstream. During the discussion, I'll come back to the story about eyes, because this is a great innovation, as is Soil Haiti, around maternal neonatal child health. And just briefly, this is a for-profit social venture. Their flagship is a $2 birth kit, which provides women with all the components recommended by the WHO for safe and hygienic birth. And through our partnership in the Saving Lives at Birth, and through what Neil outlined as a great story about the chlorhexidine, we're actually working right now with this entrepreneur in India to actually bring chlorhexidine as within their primary birth kit. They've been using it a bit. There's some social issues in India around chlorhexidine, but we're working with them to actually bring that into their portfolio. And again, they've developed a very strong ecosystem of smart partners, and we're looking at how do we use our money as really a loan investment to leverage in private investors. And the third example is in the bottom picture, which is Lionsgate Technology, LGT Medical. And this, again, came through the Saving Lives at Birth initiative through a seed grant. And the story around this is really around angel investors. So they have angel investors, for those that don't know, have been key to supporting exciting private sector startups. What's important here is that they bring the know-how, the experience, and in most cases the business scars of successes and failures. So when they approached us and they said, listen, through our seed grant, we've got this great innovation. It's vital signs. It's able to monitor vital signs and enable early diagnosis of a wide variety of areas, but one in particular, which is preeclampsia, which is a huge killer of mothers and infants around the time of birth. And to enable the scaling, the conversation with Irfan, which was the lead angel investor, went like this. He said, Andrew, I've been a serial entrepreneur for 30 or 40 years. What I like about this investment is that it's going to save and improve lives. And down the road, I can see a bit of profit, but the risk is really high. What can we do together? How can Grand Challenges Canada come to the table to actually de-risk my investment? So from my perspective, what I want to be able to do is to really to leverage in Irfan, leverage in that smart partner, because I want to tap into this particular entrepreneur's knowledge, expertise, as I said, business scars from the successes and the failures. And in addition to that, I want him to be committed to this, and I want him to put skin in the game, which he did. It ended up being in total a $2.1 million deal, and we're actually looking at another follow-on investment with them as they move more towards growth financing because they want to hit the developing world market in the next 2 or 3 years. So there's a good example of how we're looking at smart partners. So the final slide that I'll end off, these are really early lessons that we're getting from the different investments. The role of smart partners like Irfan is essential. Integrated innovation brings focus on the challenge from all those 3 perspectives. This is really important. People matter. Leadership skills and determination of the social entrepreneur is fundamental to success. You can have a great idea, but if you don't have the right people around the table to take it to scale, then it's not going to go anywhere. Public funds can catalyze private investments and engagement. And we're experimenting a lot more on what are the different instruments that we can use from grants, but we're moving further away from grants to more loans and equities. And really, what is the purpose of those loans and equities within a particular deal? And finally, learning by doing is key. We're doing a lot of experimentation, and we must be open, and I hope we are going to be open to our successes, but more importantly to our failures. So thank you very much, and I look forward to the discussion.
Thank you very much, Andrew. Bold ideas, big impact, and a better world. Yes, that's what we need. But let me give the floor to our third speaker, who is Harshad Sangvi. And Harshad will be speaking on lessons learned from maternal newborn health innovations that have successfully been introduced at scale at a national level. So welcome to take the floor, Harshad.
Thank you very much, and I'm delighted to be here today. So what I'm going to do is share with you some lessons we have learned in taking sound innovations to scale, and very specifically focus on what we as the NGO community, as the international community, as the donor community, and as champions do to make this happen. And I'll use a case study from Nepal, calcium, so that we can gain some insights. Let me start by, next slide please. Let me start by sharing with you a couple of examples of Jhpiego's history, just 2 examples. Prior to 1985, most of the training that was being done in low-resource settings was inefficient apprentice-based training. And people did not necessarily, they came out very knowledgeable but not necessarily skilled. And Jhpiego introduced a new way of doing training, the mastery learning approach, adapted it for the needs of developing nations, and competencies were assured. I believe that this was very fundamental to the needs of developing nations, especially where we had to depend on task shifting and task sharing. In other words, we were expecting not physicians to perform the services, but anybody who happened to be present in a healthcare setting, including nurses and community workers. So using a competency-based training approach, we were able to achieve this, and this has now become fairly standard. Within that particular investment, we had to develop all of the technologies needed for training at this level, including simulators, and we continue to do that to this day. And I think it has made a huge difference in the way we get a competent health force. Now, frankly, those particular investments were very non-risky, and people were willing to support training programs. But let me shift to 2000, the year 2000, when we began looking at alternatives for preventing postpartum hemorrhage. And we knew that postpartum hemorrhage was a leading cause. In Indonesia at that time, 45% of maternal deaths were from postpartum hemorrhage. Serious problem. But we also knew that more than 50% of women in that country were not delivering with skilled professional providers. And we had all of the technologies to help skilled professional providers prevent postpartum hemorrhage, but not for those women who were delivering at home. So we began a somewhat risky approach by taking a very, very sophisticated medical treatment into the hands of community workers and help women who were delivering at home. The risk here was that the drug that was being used, misoprostol, was also being a drug that can be used for procuring abortion. And I think there were lots of anxieties. And we selected Indonesia, a fairly conservative country, because we wanted to demonstrate that this was possible. And through a process that I believe Neil identified earlier in his talk, we were able to not only build the evidence, but 15 years fast forward, and we now have almost 30 countries that are having programs in community-based distribution of misoprostol. So through a variety of gathering of evidence, stakeholder engagement, incorporating into advocacy movements, firing up champions, we were able to make this happen. So I want to share with you, so those are some of our successes, but we've also learned, next slide please, from our failures. And over the years, we've had some spectacular failures. Let me just identify a few of these. Prior to 1990s, we had started working with the telecommunications technology that allowed professors from Johns Hopkins to give lectures to people in developing nations. For example, I used to be in Kenya in those days. But one of the reasons why that technology failed was that being in Kenya, I couldn't afford the $300 phone call that required me to receive an hour-long lecture. And I think it was only some years later that internet became available. And I think what we learned from the failure and what we took advantage from that failure was that we had already developed all of the content for a new platform. And when internet came, we were one of the leading organizations to be able to share knowledge in a very, very dramatic manner. Sometimes ideas fail because there was just not enough funding. In 2003, we had developed a complete strategy to replace surgical management of post-abortion complications with medical management of post-abortion complications. And we just couldn't get it financed at that time. Subsequently, the research has been done, but even today, nations, even though we have got the evidence that a medical treatment, a simple, inexpensive medical treatment works for treating unsafe abortion, is still not widely utilized. And I believe that there are many, many reasons why these ideas have not necessarily scaled up. Sometimes good ideas fail because everybody else is doing it or doing it better. Sometimes it is because we're not solving a big problem. Sometimes there is serious opposition to the innovation. Oftentimes it is because just our numbers, the impact that we are claiming from our innovation just do not add up. And certainly, probably one of the most significant in terms of taking sound innovations to scale is a lack of a champion. I often think that sometimes big ideas and great innovations or good innovations tend to fail because we only base them on knowledge rather than understanding. And I think you do have to have a deep understanding of what will bring about change even before you have embarked on creating a new technology or a new solution. Next slide, please. So I think nations often have to make some serious decisions about what it is that they wish to take forward. And some parts of that conversation are pretty obvious. So is this new innovation or new technology going to solve a major public health problem? But more important than that, is there a high demand for a solution? So right now, a lot of people are talking about gender-based violence, but not a single country that I know of in developing nations is financing solutions for that particular area of work. So, while we may think it's a big, major public health problem, there may not be enough demand or enough financing or enough support for the solution. We've also got to figure out if the innovation or technology is going to be useful in a limited resource setting, which is the big challenge in developing nations. But among all of these, I find that one of the most important insights that we need to have as we attempt to take solutions to scale is a deep understanding of whether the limitations of the solutions are going to be acceptable. For example, if we take the example of misoprostol, the fact that this same drug is going to be useful for abortion, is that an acceptable situation because the big benefits that we'll get for prevention of postpartum hemorrhage override any concerns people may have for misuse of the medication. And finally, I think the top-level decision makers often have to think about how long it will take to get to success. We have so many different health agendas that need to be addressed that if your solution is going to take a long time before big impact occurs, then it's just not going to fly. Next slide, please. So there are many thoughts about how, and I'm going to now walk through introduction and then scale. So in terms of introduction, clearly we have to think about how the innovation will affect current programs. How will it fit into current programs? And while evidence of effectiveness is really important, how it links to other things that nations and governments and providers are already doing is probably even more important. If you think of diffusion of innovation, we're trying to get to the tipping point. And there are several things that we need to work towards in getting to the tipping point. I believe that one of the most important things is in getting to the tipping point is to find the right kind of in-country champions. Champions who are going to be the early adopters of the technology, who are unafraid of failure, who are willing to take somewhat of a risk, and who are being watched by the early majority and the late majority of people, but who are going to set the trends. To me, it's really important to target that group of individuals in countries so that they are convinced about the evidence, they're convinced about how it links to their own programs and what impact will it have. And then, of course, we've got to work on a variety of different enabling tools, including global guidelines, policies, training materials that are going to be needed. Next slide, please. So there are some other steps now as we move towards entrenching innovations. I already spoke about developing champions. But one of the most important other aspects is to figure out what kind of messaging is important. So you need to figure out what stakeholders need to know. We need to figure out what individual providers need to know. We need to figure out what payers need to know. And we need to target our message very specifically to those individual groups of stakeholders. And as the innovation or technology is gaining ground, we are going to face resistance. I think one of the most important lessons we've learned is to allow a little bit of reinvention and modification. People feel very comfortable if we can tailor that particular innovation or technology to their own particular needs or their own particular perspectives. We need to do significant amount of communication to allay anxieties. We need to figure out how visiting high-performing sites will enhance adoption. And certainly there's going to be training needs. So I think there's a very significant level of investment that is needed in the process of scale-up. I believe that if you do not think ahead of time of all of the different challenges in the scale-up, then you're not likely to move beyond initial introduction. So I'm going to use the example of calcium supplementation in Nepal. Next slide, please, to describe some of the challenges and the issues. So preeclampsia is a very major problem in all developing countries and results in very high maternal and newborn mortality. We've known for a long time that calcium supplementation to pregnant women, starting as early in pregnancy as possible and running right through pregnancy, is very effective in reducing preeclampsia. So you can get almost a 50 to 60% reduction in preeclampsia by calcium supplementation, and particularly you can get this in women who are calcium deficient. Many developing nations have women who are calcium deficient. So it's an appropriate intervention. This particular intervention, even though we've had the evidence for almost 20 years, has just not taken off significantly. So next slide, please. So we began conversations in Nepal in 2007, and over the years we created a high demand for calcium supplementation. But in the process of the demand, we had to meet some significant challenges. For example, the cost of calcium. Now, iron supplementation in pregnancy has been adopted for a long time. It costs governments about $1 per pregnant woman to supplement women with iron. For calcium, that will be about $7. So suddenly there's a price point that is a challenge. There are other challenges related to logistics. Calcium is very bulky, and it requires a large amount of space to store and take to remote areas. But Nepal made a decision after a lot of discussions to address this, largely because of the evidence. And Nepal had already done really, really well in reduction of mortality from postpartum hemorrhage. And so today, Nepal's leading cause of maternal death and newborn death is in fact preeclampsia. And so calcium at that time was already part of a nutrition strategy, but it has not been implemented. Next slide, please. So one of the things that I think was very important was to try and figure out how calcium supplementation fitted within what was already existing within the government programs. At that time, the government of Nepal had a three-pronged strategy for addressing preeclampsia and eclampsia. And we added to that strategy the calcium supplementation. So it became part and parcel of a bigger attempt at addressing this thing in a much, much more holistic manner. I think this is very, very important. I don't think that any intervention should be presented completely as de novo. It has less chances of success. But if it's part and parcel of a well-coordinated overall strategy, then it has more chances of success. Next slide, please. And then the other issue was feasibility. Got to examine all aspects of this feasibility. So at that time, there was some significant difficulty in getting calcium without vitamin D. And while there was very, very good evidence for calcium supplementation, there was a lot less evidence for vitamin D. And addition of vitamin D to calcium actually reduces its shelf life. So that presented logistic challenges. I mentioned already that calcium is really, really bulky. Here's one of not even a sub-district store, and that sub-district store is completely overwhelmed with calcium required for half a year of use. So there are these logistic challenges that absolutely have to be dealt with. And certainly we had to discuss other issues about how it was going to get distributed, whether we're going to use a community setup or an antenatal care setup. Lots of discussion about dosage and compliance. So there was a significant amount of complexities in the implementation space that were relevant for the scale-up. Next slide, please. And this is an awful slide, but I think it sort of captures the incredible complexity of taking ideas from early stage all the way to scale. And there's certainly global actions that have to be done. There are national strategic choices, and then all the different stages of program implementation, special early introduction phases, the early phases, and the mature phases, and finally working towards sustainability and institutionalization. Along the way, there's much data to be collected, including readiness assessments, pilot program data, survey data, finally indicators in your health monitoring systems, and then into routine monitoring. And each of these different boxes represents certain aspects of advocacy or policy or health systems work that you have to do. Now this example is for interventions related to postpartum hemorrhage, but it can be used for any one of these different interventions. I raise this chart here in this particular conversation is because I think that if we truly want transformational technologies, then we also have to think about how they're going to get universalized. And I think we do have to think about how all of these technologies will move through. So my final slide and my final points. Now, I think that there are significant challenges to be overcome. One of the challenges is that, and Andrew mentioned this, we do have an innovation phylum, incredibly fine ideas that are likely to stagnate if we do not have a very strategic way to move forward. At an implementation level, we don't have the bandwidth to take too many new ideas to their logical conclusion. It is a challenge. And even for the ideas in which we have great confidence in, we are going to figure out how to maintain costs at a very low level. And one of the thoughts clearly is, how do you get countries themselves to make some advanced commitments so that manufacturers are de-risked early on and want to invest then in making those technologies available. There are some opportunities to exploit, of course. For example, the work of the UN Commission on Life-Saving Commodities, one of the programs that Jhpiego works in, is accelerated. It works together with the UN Commission. And I think the UN Commission on Life-Saving Commodities has done some exemplary work in reducing the burden on manufacturers to take certain products to pre-qualification. I think that kind of work is going to stimulate manufacturers to not only support newer technologies, but also make older technologies more available in developing nations in low profit margin areas. And finally, I think that there are new approaches that are likely to work. I think that we need to crowdsource these solutions from developing nations, and we certainly need to work on non-traditional partnerships. Traditionally, public health folk have rarely collaborated with engineers or collaborated with industry or social scientists or others. And I think it's time that we worked on these non-traditional partnerships because we have to develop new solutions. So let me stop there and hand it back to you.
Thanks a lot. Thanks a lot, Harshit. A lot of very healthy food for thought also for us in the advocacy community here. So the Next and last but not least, Karen Clune will be our fourth speaker. And Karen will be speaking on how the donor community should be incentivizing innovations over the next 10 years and how donors can ensure that these incentives are responsive to the most pressing maternal and newborn health needs. Karen, please take the floor.
Yes, hi, thank you. Thanks for the wonderful opportunity to join the webinar today. And actually, Harshad's last slide is a perfect segue into what I wanted to talk about today, and that's essentially one of the platforms, the crowdsourcing platforms that we have at our fingertips for funders and donors to help incentivize and deliver innovations. And I think a great platform in which that displays the catalyzing role that partnerships can play. So specifically, I wanted to speak about the Saving Lives at Birth Grand Challenge, which was the first of USAID's Grand Challenges for Development. The Grand Challenge model has been used by many other organizations, namely the Gates Foundation Grand Challenges Canada, but in 2011 it was the first for USAID. For those not familiar with the model, it's a crowdsourcing mechanism that looks to find new and out-of-the-box solutions for large-scale global problems. Before Saving Lives at Birth, USAID's traditional mechanisms for funding were to go to the world with a solution and ask groups for the best way to implement that solution. And so the Grand Challenges for Development model essentially turns that on its head and asserts that we don't know the solution and seeks those. Next slide. So what is our problem? Well, the problem is the purpose of this webinar is it looks to decrease maternal and neonatal deaths and stillbirths. And to have the biggest impact, we looked specifically around the vulnerable period of birth. Next slide. To combat the problem, there were 5 partners that joined together to launch this Grand Challenge, which were the USAID, the Government of Norway, the Bill and Melinda Gates Foundation, Grand Challenges Canada, and DFID. And as a partnership, we believe that we're able to do much more than one single funder. Not only can create a bigger pot to pool money from, but we can also leverage the experience and the reach of each other. In terms of experience, the Gates Foundation and Grand Challenges Canada were more familiar with the Grand Challenge model than USAID was at the time. And in terms of reach, each partner has their own communities that they kind of connect with and draw from. And by leveraging each of the 5 partners' reach, we were able to bring in kind of new and untraditional partners. Next slide. So what Saving Lives at Birth looks for is innovative solutions that cross-cut technology, service delivery, and demand creation. And we believe that actually the best ideas will integrate all 3 of these. And while we look for impact around the window of birth, the intervention actually does not have to occur within that time frame. It could focus on perhaps better birth spacing, nutrition, or postpartum care. It also doesn't have to be focused on just the mother and baby. As we know, many people contribute to a mother's and a baby's well-being, and so we encourage interventions that factor in the entire network surrounding birth. Next slide. We have 2 funding streams to support the continuum of development and implementation. We provide seed grants for the development and the validation of ideas, and then we also fund ideas through the transition to scale stream, which is to further refine and test solutions that have previously demonstrated proof of concept. The latter, so the transition to scale grants, are not meant to fully scale a product or intervention, but really transition it to full scale up. Next slide. So as the numbers show, we believe this model works. Since our launch in 2011, we've had 4 global calls for solutions, resulting in over 2,000 applications from 102 countries. From there, we initiate a rigorous multi-stage review process that evaluates each application that's received. The finalists are invited to Washington, D.C. to participate in our Development Exchange, which is a dynamic 3-day event filled with networking opportunities and learning sessions for the innovators. And on the final day of the event, we open it up to the public and we showcase the ideas of the innovators in an open marketplace. And then usually that afternoon, we'll announce the award nominees. Since 2011, we've awarded 61 grants to innovators and entrepreneurs from Nigeria to Nepal. A few of the ideas are listed here on this slide, and many more were kind of actually featured throughout the webinar. Last week we heard about Rice's bubble CPAP. Andrew spoke about the Odin Device, which is the first assisted delivery device since the vacuum and the forceps. Neil spoke about chlorhexidine earlier, which we're helping to support scale in Nepal. And in addition to kind of those solutions, we also have demand creation solutions and service delivery that involve insurance schemes, e-vouchers, training models. And these really all kind of come together in creating this very diverse and we think impactful portfolio. We think, but we haven't necessarily tested the assumption, that our continued call for maternal and child health has triggered new thinking in this space. Essentially, we think that ideas will follow funding, and that by having a repeated and annual call for solutions will incentivize global problem solvers to think more about what can be done in maternal and child health. Next slide. As Harshad spoke about, and several of the other speakers have mentioned, one of our lessons learned is that even the most promising solutions can face challenges when scaling. And so to help design and support strategies to deliver and scale the impact of our innovators, we've partnered with several groups. So the NCIA, which is the National Collegiate Inventors and Innovators Alliance, the Lemelson Foundation, the Gates Foundation, and Duke University, to really provide acceleration support and mentorship to our innovators. Next slide. And so with this, I just wanted to thank you guys all and invite you to our development exchange, which is going to be August 1st, Friday in Washington, D.C. And everybody is welcome, more than welcome, to attend. In the morning we'll have our, as I mentioned, kind of the open marketplace, which will feature our 60 kind of current grantees and that we've supported from the past 3 rounds, as well as the about 60 finalists as well that will be competing for the round 4 awards. And those will all be at the exchange in the morning, and then in the afternoon will be kind of this high-level final forum. We'll announce the award nominations, and hopefully we'll get in some great kind of out-of-the-box speakers lined up to kind of motivate and inspire everyone moving forward. So thanks so much.
Thanks a lot, Karen. Thanks a lot. And now we will be getting into our Q&A session for the next 20 minutes, 25 minutes. But I think, kind of just looking at the fantastic input we have gotten from our 4 speakers here, I can say things standing out: delivery, solutions, sustainability, scale, success, people matters, and partnership matters, messaging matters, and we need the champions to help champion all of this. But thanks a lot to everybody who've sent questions. We have received a lot, but keep them coming. And I would like to start with a question that can go to the whole panel, or you can pick who would want to chip in on it. And that's what is the most important thing the maternal and newborn health community can do to support the scaled introduction of game-changing innovations? It's a tall order, it's a tall question, but who would like to go first? The most important thing.
It's Andrew Taylor here from Grand Challenges Canada, and I'm going to go back to what I'd mentioned around the role of funders, and where we have to be smarter. We have to be more innovative in the way that we're looking at this problem. And just to say that I think you're starting to see that even through this webinar, where you're bringing in the years and years of experience of the USAID angle, and Karen did a great explanation of really the saving lives at birth. So I would say that the pipeline is being generated, and where, to answer your question, the community needs to come together, I think, is really around testing new ways of transitioning these innovations to scale, and by looking at new areas of investment. So I talked a lot about angel investors and impact investors, and I think as a community we need to be able to really go after these potential investors and say, listen, there's an advocacy play here. We need to do it. Mothers and babies are dying. But there's also an argument to be made that a lot of these innovations can be profitable. You can get that social return, saving, improving lives, and you can make a profit out of it. And that's just going to come naturally through examples and testing and testing. But I think there is an advocacy play there around this so-called impact investment asset class that is currently there but untapped. So that would be my response.
Thanks, Andrew. Karen, Neil, Harshad?
Let me make a comment on this, Harshad. I think from an implementation perspective, we absolutely need to trim down the number of new ideas or new processes or new technologies to a manageable number. So we need a clear process that takes all of these incredibly fine ideas and figure out how we can trim down to a small number of technologies or interventions that governments in countries are willing to rally around and move forward. Now, I understand that it is difficult because every inventor believes they've solved a problem and will solve the problem. But I think the capacity of at least the least resourced countries to take on many new ideas or interventions is limited. And I think we have a responsibility to take some of the very, very best, most transformative, most effective ideas and push very hard to get those scaled up in countries.
Thank you very much, Harshad. That lends itself to another question we received, and that's about kind of the many pilots of innovation for global health that we see in countries, and the person asked, so how does your organization, USAID Grand Challenges Canada, Jhpiego, measure the impact of innovation its funds are implemented, and also in order to prioritize?
Well, speaking from saving lives at birth, yes, we have seen that there is a lot of kind of pilots being out there. I think what we look for is really those nuggets of what we think are kind of the ones that are going to go beyond the pilot, that they have a sustainability kind of plan in place and they're thinking ahead of just beyond the pilot. It's not so much if we build it, the government will come and continue it. It's really thinking through that strategy about how to get from that point A to point B, and if the pilot is successful, what are the kind of partners that they need in place, the advocacy, it's the policies, there's so much kind of around getting something beyond than just the pilot. And so looking at that, when we see an idea, does it have kind of, is it supported by the government? Is it, their policies, and does it have maybe the potential to scale even beyond this country? So kind of all those nuggets of sustainability, that's essentially what we look for, is that something to get beyond that pilot stage.
And it's Andrew, and I would agree to that. So when we look at a potential innovation, just to add on to what Karen said, it's just we look at the concept, we look at whether or not they've been able to prove it, and we have a really strong focus right down. I mentioned during my talk around the end beneficiary. Who is that person that you're trying to address, right down to the actual individual? And by doing that, and so we go through a whole measurement and impact around how many lives they're saving and improving. Obviously, it's going to be low at the proof of concept stage, but really around how are you accessing end beneficiaries, accessing the intermediaries, and what's your way to be able to do that? So in addition to looking at the entire ecosystem, we're looking at right down at the end beneficiary. And then going back to the notion of integrated innovation, when we get down to actually making decisions, what we've done is we look at it from a science and technology innovation. So we have an independent scientific review of some of the top experts around the world within a particular area. But we have developed an actual investment committee. So we brought in the venture capital way of doing things, where imagine around the table you have your business innovators, which are your venture capitalists. You have your scientists and the scientific input. And then you also have social innovators. So on our investment committee, we have 2 social and policy innovators because you have to look at all these different angles. So it's a great question. The bottom line is, got to look at who the beneficiaries are, and to add on to what Karen said, what are those different nuggets to be able to see and be able to really validate whether or not this innovation can reach end beneficiaries, and then getting smart people around the table to help you to make these sorts of decisions to move forward.
Yeah, let me contribute to this as well. I think in one of the most important things about any new innovation is how does it function in a real setting. So we will get effectiveness information early on through trials or other things, but in addition to that, we require, is this safe in a real setting as opposed to an experimental setting? Even more important is it feasible to implement in limited resource settings outside of big centers, perhaps? And finally, is it going to be acceptable to health workers and to clients? I think from an implementation perspective, each of those 4 elements, the effectiveness, the safety, the feasibility, and the acceptability, are essential endpoints to measure in the introduction stage of innovation. Subsequently, those kinds of measurements will need to change to just the regular routine health systems monitoring that is done. But certainly in the early stages, those are critical to get.
Thanks. And I think it is striking and very saying that all of you in your presentation mentioned the need to engage partners across sectors in order to effectively scale up. And one of the questions that we have received is goes like this: one of the largest challenges to deliver is inter-organization coordination. What are the most effective mechanisms to coordinate the various parts of this global effort? Many of you hinted at it, but would anyone want to say the most effective mechanism to coordinate?
It's Andrew here, and I'm going to throw out a business term, but really there's 2 aspects to this. The first is, I mentioned in the lessons learned, people matter. So at the end of the day, it comes down to, if you have a set of partners around the table, be it large organizations, multinational corporations, it's the people behind it, the people that are at the table, that is extremely important. The other thing that we're learning, and here's the business term, it's skin in the game. So when you have partners around the table, what we're finding is the best way to have commitment is not only alignment of values, but more importantly is whether or not they have actual skin in the game. And what that means is really, if we're looking at a $3 million deal with 2 or 3 different partners, well, what do those partners bring to the table in terms of their expertise, but also in terms of their commitment? And so what we're finding in a lot of the investment deals is that those that have skin in the game are ones that are going to be more aligned and more committed going forward.
Thanks. Anybody else want to?
Yeah, let me contribute.
Yeah.
How do you create these kinds of partnerships? I think Andrew is really right. I think, first of all, every partner must feel that their contribution is going to be valued within that partnership. Let me describe a partnership that Jhpiego has with biomedical engineers as well as industry. In our early work, we had a very strong partnership right here at Hopkins between Jhpiego as a public health group and biomedical engineering. And frankly, it was an incomplete partnership till we were joined by Laerdal Global Health, a commercialization partner. I believe what that has done is a process of development that went right from early stage thinking all the way to implementation that came together early in the conversation as opposed to sequentially. And I think it's really important that these kinds of partnerships, creative partnerships between industry, public health groups, and technology-based groups begin very, very early in the process so that all kinds of stakeholder inputs can be evaluated along the way. If we use a sequential approach, then I think it takes a lot longer. One good example from our own work was something that the Savings Lives at Birth grant supported. This was just a training mannequin for postpartum IUD insertion, a new technique for insertion. Within a 2-year period, we were not only able to conceptualize the idea, but develop the model, manufacture the model, and then take it out. And it's already in 10 countries, 10 markets in those countries. So to me, that would have never been possible if all 3 groups or all 4 groups or all 4 partners had not come together right from up front to move the process forward. And I think that's very critical in any partnership.
Hi, this is
Thank
Neil.
you.
Maybe to add to that, I did think there are 2 other elements that are worth considering. One is one needs to have a good sense of timing, that not everything comes together in the way one initially imagines, sometimes faster, sometimes slower. The other is the extent to which one creates an environment, realizing there's always inherent competition among different groups, but one needs to create environments, in fact, that bring a larger community together in a way that, in fact, there can be a greater mutual benefit or value added of, in fact, sharing information.
Thank you. And also, if I may add, and it echoes what some of you have said, coming from an global advocacy organization like Women Deliver, kind of the role of advocates in general in the whole work with innovative solutions. It's also to get the advocates in at an early stage so that the advocacy is addressed and all the different level that has to happen on in order to take things to scale and to kind of open the doors and pave the way. That's kind of one of the takeaways I have from listening to all these to the 3 webinars. That definitely it's all the different elements and all the different partners that has to play together and do it at an early stage. One question that we have gotten is that I'd like to put to everybody is, so how can we get advanced commitment to buy into new technologies at country level? Of course, there are many, but what is it that we can do to get that commitment? Because as we know that the national level plays such a crucial role. Would anyone take a shot at that? And I can just say it again. So how can we get advanced commitment to buy into new technologies at country level?
Katya, let me just, I think about this often. Let me take a crack at this. I think that we need some global mechanism by which groups of countries can come together and say, look, here is a new technology that we truly believe in and that we will commit to using it should it become available. The reason for doing that is manufacturers are not lining up in large numbers to support technologies that are sort of somewhat risky and have low profit potential. We have to, I think as Andrew said, we have to de-risk their investment. And I think one way of de-risking is getting a few countries in a region to come together to make that commitment. I think that in many ways the advanced commitments and the global commitments made for, say, malaria products or for HIV products really drove industry to produce those kinds of technologies that were needed. And I think it was mutually beneficial to have that happen. I think for maternal and newborn health related technologies, there isn't necessarily very sound global mechanisms to make that happen. And I think at the end of the day, for sustainability purposes, you need countries to come together. So we need some sort of global mechanism that can get countries to commit to saying, okay, if such a product was available, if this thing is available, then we are going to commit to buy X amount of product. To me, if that happens, then manufacturers and industry would be more likely to want to take the risks to further develop the product and make it commercially available.
Maybe to add to that another dimension, I think that in some cases advanced commitments may not be possible, but rather one needs to lay out the value proposition of the technology in a sufficiently compelling way that the demand will follow.
I agree with that, and just from our, this is Andrew, Grand Challenges Canada, just from the early lessons that we're learning around these 15 to 20 deals, there's a number of them where the actual smart partner coming to the table is the local developing country government, which has been a bit of a surprise, but when we really start to do the analysis around it, we're saying, well, the ideal smart partner in all these deals are the local developing world government. So we're spending a lot of time on that. And in one particular deal, it's one where they're looking at addressing schistomiasis in Senegal. And schistomiasis lives on snails. When they broke, and it's shrimp that eats the snails keeps the level of schistomiasis down. When the dams in Senegal broke along the coast 10 years ago, the shrimp died, schistomiasis increased. And so there's this great enterprise that's looking at how do you mass produce shrimp in a natural way that can then be inputted back into the freshwater to bring down the levels of schistomiasis. And so there's a great science and technology side there. The social side is really interesting because they're looking within the local environment. But what's really interesting is that it's the Senegal government that's really interested in this and actually bringing their own cash and skin in the game because they want to come in as building the shrimp hatcheries because it's actually jobs for their for the local people to actually grow these shrimp. So we're looking at this from a deal-by-deal basis, but that's really a good example of how as he said, the value proposition, I think, is exactly right. It's the value proposition that, hey, not only is this going to address schistomiasis, but it's going to create jobs for the local economy within these Senegal communities.
Thank you.
I think there's also...
Karen, go ahead.
No, sorry, I was going to say, I think that there's a lot of platforms that are starting, that are kind of in the beginning stages, that I think will help kind of catalyze some of these innovations and at least their awareness of them between, say, the kind of the newborn campaign and the I know that there's a GDA with at USAID, the Survive and Thrive, that works with a lot of professional, kind of international professional associations, and you know, with the UN Commodities Commission, if they can kind of create awareness and push some of these ideas out there, whether it's, you know, the chlorhexidine or the resuscitation devices, that perhaps then then the next level would be creating this kind of the global mechanism that Harshad spoke of.
Yeah, good. Karen, we actually got a very specific question for you, so that I'll take the opportunity to ask. It's after 4 rounds of saving lives at birth and through the accelerator, can you say if you've noticed a change in the quality or preparation of the ideas as far as considering implementation and scalability?
Yes, no, I think we have. Between the 4 rounds, I mean, also a lot of it, it's a learning process for us as well. And after each round, we do a pretty thorough analysis of our review process. We look at, we ask the evaluators, what did they think about their criteria? What could be better asked in the application? We also ask, a lot of the participants themselves for their feedback kind of on the process. We're also in the midst of kind of starting an internal, an evaluation on the program itself to really think about, what is our niche, where we're going, how are we doing, the kind of the impact that some of our innovations are having. And we've seen, I think, through all of these things combined, better quality ideas. It was an experiment to see kind of what we would get and where we would get them from and the ideas, and if we would continue to get good ideas across 4 rounds, or if they would kind of stall, say, after the first one. And I think we've seen it. As I've said before, I think the assumption or the thought is that by kind of having this annual call, we've incentivized people to start thinking about new innovations. And so perhaps the first round we kind of tapped into ideas that were already out there, and then with each round we're kind of sending the call out again that we're still looking for new ones. And we've certainly seen, I think, a lot more come from developing countries. So in our 4th round, we received over 55% from developing countries, which was the highest percentage yet, and incredibly, I think, exciting for all of the partners, because the belief is that probably the innovators themselves from the countries kind of with the highest incidence of maternal and neonatal mortality might have the best ideas. We've certainly seen kind of more partnerships come to the table, so that say an innovator in a developing country work with a university or a kind of another implementing partner from a kind of more high-income country. But then also certainly some ideas have been kind of a bit repetitive, but people are continuing, I think, to push the boundaries, and so we've been incredibly exciting by the response.
Thank you. And time sure flies when you are in good company. It's almost 12 o'clock. We will be going a little bit over time because we're getting so many good questions and comments. So I have a question that's kind of also linking back. Just one more question linking back to where we started in the first webinar, but then I'll give all the speakers the opportunity for a 30-second little sum up. But the last question here would be, so what can the design community learn from the successful scaling up of global health innovations that would influence the early design and production decisions?
I think reaching out to the end user is critical. I think we've seen several ideas come through that it was questionable, actually, if they had ever kind of been to the field and kind of seen that real life setting, if they had interviewed and talked to perhaps women and children or the doctors to see if this actually would be in use, or if it's too high tech, too high of cost. And so all of those, I think, design is critical, and really thinking about kind of the end user at the very beginning of the process and how to incorporate it. If it's a literacy, if it's a kind of a technology or mobile device, what if the person, illiterate community, or they don't have, the phones. Like, there's so many things I think that go into the design of it itself that really need to be taken into consideration at first.
Thank you, Karen. Neil, would you have a comment for this one?
It's actually a really challenging area, and one that we struggle with. the researchers who I work with tend to want to begin with a set design they're most comfortable with and really test it at a proof of principle. Where we've been trying to challenge the research and design community, as Karen alluded to, is to work on sort of an early feasibility utilization phase before one actually moves to the next stage of proving whether something's effective. And that's not necessarily a comfortable area for many in the research community, but in fact, where it can be done, it's an essential element to ensure that what you're doing makes sense at the end of the day.
Thank you. So let me just ask all the four speakers to give us a final thought and a final takeaway from this webinar. Will you start, Andrew?
Sure. I think it's been excellent. We need more of these webinars because it just gets to my final thought that we really need to look at this as an experiment. We're testing different things here, and with every experiment, you're going to have successes and you're going to have failures. And we've got to be able to not only talk about the successes, but more importantly, talk about the failures, because no one single organization is going to be able to figure this out. And but I'm optimistic. I think just in the grand challenges type of community, we are coming together. We're having these sorts of discussions. What works? What doesn't work? And I think we need to continue doing that. And as funders, we need to continue to innovate because we're asking our innovators to innovate. We in turn need to continue to innovate.
Thank you. So true. Karen?
No, Andrew had some great ones. I agree completely about how the need to kind of continue to innovate. Also, I think to kind of moderate and iterate as well as we think about as from funders what's working and what's not. I guess my big one would be partnerships is key. Kind of no one person or one kind of organization can do it themselves. From a funding perspective, Saving Lives at Birth, is a partnership, and we, between the 5 partners, we pool our funds, we leverage the expertise, and also from, in terms of the innovator perspective, I don't think that kind of any one person can do it as well. And so we have seen kind of more partnerships come through together. And as I really think about kind of who they need to partner with, kind of on the continuation from kind of ideation to scale.
Thank you. Very true. Neil?
So maybe to add 2 related thoughts which have already been brought forward. One is that at risk of sort of bringing a research concept, one needs to approach these efforts with a research mentality in the sense that you have a theory of change or theory of action. And with your innovation or your product, you're constantly revisiting that to see the progress you're making. And the need really to have the courage to use, I think, the concept that our colleagues at PATH really brought forward, which is having a go, no-go concept around whatever you're working on so that, in fact, you have the courage to move forward and as well as to stop.
So true. And Harshit?
Yeah, from my perspective, I think one of the most important things we perhaps need to do as a global community is to set ourselves some very hard targets and standards. I think this would help industry, this would help countries if we made some decisions on a small number of perhaps technologies that we really do want to scale. So we do need a global process for a robust and impartial system for selecting the very best of technologies, because implementation and scale up is so time consuming and costly. So we do have to find a way to trim down what could potentially be an innovation pileup.
Thank you. And I think by this we will end this webinar that was focusing on deliver and delivering. And I would like to thank the 4 speakers for surely have been delivering over the last hour and a half some really, really good points and healthy food for thought that we can all take with us in our future work in this area. Thank you very much, and thank you very much for letting me moderate. It's been an absolute pleasure.
Yep.
A good day and a good evening to everybody.